In sepsis, the first warning is not always a dramatic blood pressure crash. It may be a patient who is sleepier, breathing faster, making less urine, or simply looking different from an hour ago. The bedside nurse is often the first person positioned to notice that change. In the next few minutes, we will build a practical approach to recognizing early patterns in organ dysfunction, escalating with concise, high-value data, supporting evidence-based resuscitation priorities, and reassessing both response and emerging harm. The goal is simple: recognize earlier, respond in parallel, and keep asking what the patient is doing now. Sepsis is infection plus life-threatening organ dysfunction caused by a dysregulated host response. In the setting of suspected infection, an acute qSOFA increase of 2 points or more supports organ dysfunction, but sepsis remains a clinical syndrome, not a single laboratory result. Infection may remain localized. Sepsis means that infection is accompanied by acute organ dysfunction. Septic shock is more specific. Vasopressors are required to maintain a mean arterial pressure of at least 65 millimeters of mercury, and lactate remains above 2 millimoles per liter despite adequate volume. Keep the logic connected: suspected infection, a harmful host response, and new organ dysfunction at the bedside. The sepsis cascade produces vasodilation, maldistributed blood flow, capillary leak, and impaired oxygen use. That is why one acceptable blood pressure reading does not guarantee adequate tissue perfusion. Watch the whole patient and watch the direction of change. In the brain, look for new confusion or restlessness. In the lungs, rising oxygen need or tachypnea. In the kidneys, oliguria or rising creatinine. In the liver, rising bilirubin or coagulopathy. Circulatory clues include hypotension and mottling. Hematologic change may appear as falling platelets or bleeding. No single finding tells the entire story. The pattern and trajectory do. Early clues may be obvious or easy to miss: fever or hypothermia, tachycardia, new confusion, tachypnea, increasing oxygen need, hypotension, falling urine output, delayed capillary refill, mottling, cool extremities, or the sense that something is different. Verify that pattern quickly. Risk is higher with older age, immune suppression, chronic disease, invasive devices, wounds, recent surgery, hospitalization, antibiotics, or a likely lung, urinary, abdominal, or skin and soft tissue source. Risk raises suspicion. It does not diagnose sepsis. SIRS is sensitive for inflammation, but is not specific for infection or organ dysfunction. qSOFA uses respiratory rate at least 22, altered mentation, and systolic pressure at most 100. It is a risk flag, not a standalone screening test or rule out. SOFA tracks dysfunction across 6 organ systems. Use your hospital's validated screening and escalation pathway together with clinical judgment. When a patient changes, use a rapid, repeatable scan. For airway and breathing, check the airway, respiratory rate, work of breathing, and oxygen saturation. For circulation, assess mean arterial pressure, pulse, skin temperature and color, capillary refill, and reliable vascular access. For disability, compare Glasgow Coma Scale or mentation with baseline and check glucose. For exposure, note temperature, search for a source, and inspect relevant devices. Then deliberately assess perfusion, urine output, lactate trend, and mottling. This scan does not replace a full assessment. It organizes the first minute so deterioration is recognized, communicated, and acted on without losing time. In the first hour, think parallel work, not a slow sequence. In the first minutes, recognize the pattern, activate the pathway or call for help, apply monitoring, verify access, and provide oxygen as indicated. Measure lactate and remeasure it when initially elevated. Obtain blood cultures before antibiotics when doing so causes no meaningful delay. Send the needed laboratory studies. Appropriate empiric antimicrobials should begin immediately, ideally within 1 hour for shock or a high likelihood of sepsis. Begin rapid crystalloid for hypoperfusion or shock. If hypotension persists, support a mean arterial pressure of at least 65 with a vasopressor as ordered. Cultures, antibiotics, perfusion support, and source control planning should move together. Before administration, check allergies, prior cultures, renal and hepatic function, infusion compatibility, and the exact administration time. The safety principle is clear. Cultures first when feasible, but do not create a meaningful delay in readying antibiotics. For initial fluid resuscitation, the presentation favors balanced crystalloid. 30 milliliters per kilogram is suggested for sepsis-induced hypoperfusion or shock, but it must be individualized and followed by reassessment. After an intervention, check mean arterial pressure, capillary refill, lung sounds, oxygen saturation, urine output, mentation, and dynamic response. Then adapt. Does the patient need more fluid, a vasopressor, or a stop because harm is emerging? This is active resuscitation, not fluid on autopilot. For vasopressor support, norepinephrine is first line, with an initial mean arterial pressure target of at least 65 millimeters of mercury. If response is inadequate, the team may add vasopressin and consider epinephrine. Peripheral initiation may be appropriate to avoid delay when the line is proximal and closely monitored, but it must follow institutional policy. Continue tracking both perfusion response and pulmonary tolerance.
Lactate is a clue, not a diagnosis. An elevated value may reflect impaired perfusion, adrenergic stress, reduced clearance, seizures, medications, or other causes. Interpret it beside capillary refill, skin findings, urine output, mentation, hemodynamics, and the patient's trajectory. Repeat lactate when it is elevated, and use the trend to judge response, but never chase one number without reassessing the patient. The work is a loop. Assess mean arterial pressure, mentation, urine, and skin. Intervene with fluid, vasopressor, oxygen, or source-focused care as ordered. Measure lactate, output, and respiratory status. Then adapt by continuing, escalating, or stopping harmful therapy. Treatment is not finished when an order is completed. It is finished only when response has been evaluated and the next plan is clear. Antimicrobials cannot drain an abscess, relieve an obstruction, or remove an infected device. Keep source control visible from the beginning. For a lung source, consider secretions, imaging, and ventilation. For urinary infection, urine findings, obstruction, and the catheter matter. For the abdomen, look for pain, distension, and drains. For a line, examine the site, cultures, and removal plan. For skin, assess wounds, pressure injury, and necrosis. Escalate with SBAR that drives action. New hypotension and confusion, sepsis suspected. Give the source and risk background, admission context, cultures, devices, and antibiotics. Report vitals, MAP trend, oxygen, urine, lactate, and examination findings. Then make an explicit request. Please evaluate now, activate the pathway, and place orders. Document the first change, recognition, escalation, data, actions, and response with precise timestamps. That protects continuity, quality reporting, and the patient.
Consider a 68-year-old patient, postoperative day 2 after colectomy. At 7 o'clock, the heart rate is 96, blood pressure 118/66. Oxygen is 2 liters by nasal cannula, and the patient is alert. Later, the heart rate is 112, respiratory rate 26, blood pressure 102/58. The patient is sleepier. Urine output is 15 milliliters per hour, and temperature is 37.8 Celsius. The absence of a high fever is not reassuring. The change from baseline is the clue. What should happen in the next 5 minutes? Call for help or activate the pathway. Perform a focused airway, breathing, circulation, and perfusion reassessment. Apply monitoring. Verify intravenous access. Prepare lactate, laboratories, and cultures, and communicate the exact trend with SBAR. After 1 liter of crystalloid, the MAP is 58. Lactate is 4.1 millimoles per liter. Oxygen need is increasing, and the knees are cool and mottled. Shock is emerging. Escalate immediately. Continue ordered resuscitation. Start norepinephrine per order and policy. Track response and pulmonary tolerance, and expedite source control.
Knowledge check. A patient with suspected septic shock has cultures ordered, but the blood draw is difficult and antibiotics are ready. Should you wait for all cultures? Give antibiotics now while culture attempts continue. Wait for repeat lactate or send the patient to CT first.
The best answer is B. Give antibiotics now and continue culture attempts. Cultures are important, but not when collection creates a meaningful delay. Common pitfalls follow the same principle. Do not wait for fever. Act on organ dysfunction and trend. Do not trust one normal blood pressure. Assess MAP, perfusion, and trajectory. Do not give fluid on autopilot. Reassess after each intervention. Do not use qSOFA as a rule-out. Combine clinical judgment with the local screen. Avoid vague escalation. Use SBAR and an explicit request. And do not treat the bundle as a checkbox exercise. Treat, measure response, and adapt. Recognize new dysfunction, concerning trend, source clues, perfusion abnormality, and high-risk context. Then activate, monitor, obtain access, measure lactate, attempt cultures, give antimicrobials, support perfusion, reassess, and document.
5 actions can change the trajectory. 1. Notice the change. 2. Name the organ dysfunction. 3. Activate early. 4. Start care in parallel. 5. Reassess relentlessly. Sepsis care is not one number, one order, or one completed bundle. It is rapid recognition, followed by coordinated treatment and repeated evaluation of response and harm. This education is based on the source presentation by Patricia Ann Sutherland, BSN, RN, with practice guidance including Sepsis 3, the Surviving Sepsis Campaign, Society of Critical Care Medicine Resources, and CDC Hospital Sepsis Program core elements. Always follow current institutional policies, order sets, and scope of practice. Notice the trend. Name the dysfunction. Activate the team. Recognize, then respond.